Hello, good morning.
Have a seat.
Well, thank you so much.
We'll just do a little sit and chat here. And this is a time in the past and today that you have used in part to reflect on what we heard in day one from the first day of Transform. And so just start us off there. What are your takeaways from what we did yesterday?
So, if you think about some of the things we heard yesterday in the morning, we heard how we can approach problems of health, both from a public perspective, in particular how the Commissioner of Health in Baltimore found ways to work. But there are some remarkable examples of private investment that are making a big difference. And then in the afternoon, there was a wonderful discussion about technologies that would make people's lives easier. But the thing that was kind of missing from that one, from my perspective, was that there wasn't much discussion about how doctors will actually use all of this fancy stuff and how we can change what we do that will make people's lives better. I think Tom Insel began to get a bit toward that. Dr. Decker got a little close to that, but not close enough from my perspective. There were some other observations that came out of those first two sessions. Cyrus Bethea, in fact, had a neat little slide that showed all the parts that have to work together with a little dotted line in between them. And I think the dotted line could imply several things. One is maybe we think that's where it should be, but maybe we don't know what it should be. Yeah. So from my perspective, the great opportunity for innovation is to innovate that integration of all the pieces. And that may be, in fact, what we are really missing. That's something that we've thought about a lot here at Mayo, how we can actually innovate that integration of different pieces that would produce a better experience of health. And I thought the debate was quite interesting in terms of staking out a position about whether this is going to be a government solution or a non-government solution. And then after the discussion, we kind of arrived somewhere close to the middle, maybe, that you need both government and non-government solutions, and we could talk, in fact, more about that. Yeah. I certainly reflected a little bit about some of the government things. What was not said in the debate that I thought was missing was that there's a great deal of dissatisfaction with the current delivery system. Burnout is high among physicians, and almost all physicians emphasize that the medical record is a part of that, the electronic medical record, and its clerical burden. And to be blunt, really a lot of the reason for that is because government has applied a series of regulations to how the electronic environment will work based on the way that we practiced in the 1990s. So the entire structure of how the electronic medical record works reflects rules that were written in the 1990s when we were still writing medical notes on paper. So obviously there's an opportunity for innovation, thinking about how the private sector might do it, and then how the government might ask about what it is we're trying to produce. And by the way, for those of you who have been to Transform before, I think you realize or recognize that we have emphasized that the real product that is important is health, and that health does not mean health care, and that we need to really understand people and the people where they are. So what we're trying to accomplish in Transform this year is to look at this from different dimensions and lenses to find out again how we can innovate all the pieces together. So some of us may work on one thing, some of us may work on another, but if we all remember that somewhere in the middle we have to integrate that integration, I think we'll be very good. And
there's a lot to unpack there, which we will, but just a reminder that we'd love to hear your questions for this session as well. So keep going online at polev.com/TXFM. So I want to unpack one of the things you said there, because I think there's again a nuance there that I would like to explore. Innovate the integration. I don't want those words to just fly past our ears without giving that a little bit of time, because what you're talking about isn't, we saw the examples from Patty of all of the innovations happening, all of the eyeglasses and headsets and olfactory, stuff, the gizmos, whatever you want to call it, that are right. Coming online. That's the innovation happening there, that happens. But to innovate the integration, to actually then use that as a practitioner, as a doctor, in your daily life, or as a consumer, as a patient in my daily life, that little muddy place between inventing something cool and actually using it, that's where things aren't happening. And just before you answer that, I mean, it's just interesting to think about the innovation of the iPhone or of the smartphone, and how quickly we all integrated that into our daily lives. So why isn't that happening with some of these medical advances that aren't smartphone apps?
It's a great question. The iPhone, and perhaps its predecessor, the iPod, and the services that ran on it, were successful because all of those innovations made the lives of people easier. And you could find ways to use those tools in ways that were most productive individually. And one of the difficulties that we encounter in medicine is, again, going back to the fact that the payment rules are written in 1994 practice. So practice would be totally different. And just to give you an example, Dr. Wyatt Decker yesterday showed you a little device you can put your fingers on and will record your electrocardiogram. Now, from my perspective as a cardiologist, so somebody who actually is interested in getting heart rhythm disorders, if I wanted to make sure that I got paid and that Mayo Clinic on my behalf got lots of stuff, I would tell somebody who had a heart rhythm disorder, whenever you have that heart rhythm disorder, rush to the emergency room and have them record your electrocardiogram. So how many of you have had a great experience at the emergency room and getting in? And how many of you have had a great experience with the bill afterward? So then you get that information back. It finally gets back to me, and then I might be able to call you days later. But with these little devices, I can actually tell somebody, look, we need to get this thing recorded as quickly as we can. And there's a neat little $99 device that you can attach to your phone. It doesn't matter the difference whether it's an iPhone or an Android or whatever. I mean, it works. So go buy it. When you have trouble, open it up, record it, send me the email. I'll be able to see it. I can call you back or text you back or write you an email back and tell you what it means and whether there's anything we got to do. It works really great. Now, I don't get paid for that. Mayo doesn't get paid for that, but it's a big difference for the individual. So in between there's a way we have to figure out how are we going to change what we're actually trying to accomplish in medical care delivery. So first is I have to be comfortable in saying, I'm going to now become a partner with my patient, as opposed to the usual routine of me seeing somebody and saying, this is the way you must do it. So if I followed traditional methods, I would say, really, you got to go to the ER, do it this way. But that's not really true anymore. So there are ways we can change that. But the regulation and the payment are not following.
And the regulation and payment, those are the walls. I mean,
and they always, there was another line yesterday I thought was great. Let's not have innovation at the speed of regulation. And as I said, if I were doing the debate yesterday about government, I would use the example in Medicare of how far back the regulations are actually written. We'll overcome that with time.
Do you sense, though, one of the questions or things, and this is actually something that I got from speaking with you before as we were preparing for this conference, the difference between being innovative and transformative. First of all, how do you see the difference? But secondly, are all of the things we learned about yesterday, like the headband and the eyeglasses, are those transformative or only innovative, or is it, like only when it's used, that kind of a thing? Like, how do you differentiate those?
So certainly some of those are innovative and some are transformative, and if you put all of them together and created a totally new experience that hasn't existed for people, you would have a transformative innovation. And that's kind of what the iPhone or the smartphone has been. Transformative. We've barely touched the power in those devices. And when you think about what Dr. Insel was reflecting yesterday, there's a really important piece there. So in traditional healthcare, we've fragmented it. We say, okay, because of the way we pay physicians, you have to go have an office visit, a transaction that you can recognize and pay for. Or you got to go to an emergency room, you got to go to a hospital. And they will see you for a short time. They'll talk to you, then you go back and you live your life, and there's little communication between then and the next time something happens. So it's a very discontinuous, disrupted way of helping people enjoy health. But with technologies that are going to be constantly on, as Patty suggested, if I can then get that information back, perhaps another thing that we didn't talk about yesterday, but use machine-based learning in a way that I can process the results and get from all of that data, and there's a huge amount of data that's going to be out there. If I can get from that a few little nuggets that will tell me things are either on track, or they're way off track, or they're about to go off track, then I have a much better possibility of avoiding an expensive hospital stay, or avoiding a change in a person's health status that would be disruptive for them.
But I could see from the roster of things, and frankly, even some of the things that Tom was talking about with the work he does on mental health, the products, for example, Patty was talking about, I could see where, buying the glasses or buying the headband or whatever, that the right people get paid in that scenario because you are actually buying a product.
Right.
So I can see where some of these innovations will medical devices, right? A pacemaker, right? That fits very well into the medical world because we get billed for it, et cetera, and the right people, or I suppose there's a debate about whether the right people get paid, but whatever, right? People get paid. I'll save that other debate for another day. The simple idea of Dr. Wood texting with a patient to say, get out your app and do this for me. In that scenario where there isn't something for the person to buy that you get paid for or to bill for, how would you then, as the doctor, thinking about this in the future, how would you want to get billed or paid for that service?
Well, I think we have to change the conversation and start from what makes a difference to people. So the payment system is based on illness or sickness. It's not really based on keeping people well or healthy. And in previous Transform conferences, we've emphasized that the definition of health really means that people are able to live their lives in the way that they need to. They don't want to be defined by their disease or illness, and we shouldn't really pay for things that way either. So if we stop thinking about how we do that and said, okay, well, let's pay for the outcome of health, then that would be a lot different. And if I were paid then for the outcome of health, then my job is to actually focus on keeping people at home and at work and in school and at play without having to come to see me in the office, without having to go to the emergency room, without having to be in the hospital. So if you've done any of those, I've disrupted your life and you may not be very healthy. So if we change the conversation to one of producing health and say we're going to pay for health, I think that would be one of the transformative changes that would actually allow us to move forward faster.
What's one example of how that would work in real life? How with this transformed way of thinking about how you get paid and what you're being paid for, just give me one little example of how you and I would interact as a patient and doctor that would be different in how you actually got paid.
So in that circumstance, I would actually take time to know more about you as an individual and what was important to you in your daily life, what was important in terms of being able to work and things like that. I'd also understand some of your preferences related to how you like to have an interaction. Some people don't like to use technology. Sometimes a telephone works just fine. So I have to really understand you as a person. And right now, we actually don't train physicians to take any time to understand people for who they are. And again, going back to the regulations of 1994, there are check boxes. I have to check off all the things, questions about all of the body systems you have and whether you've had anything else. But there's no requirement that I actually take any time to understand you as a person. So I'm using a one-size-fits-all approach for everybody, and I know it doesn't work.
I don't go to my mechanic until there's something wrong.
Right.
Sometimes I go for preventative care, like an oil change.
Sure.
But it sounds like you're talking about a system where I'm paying you to not see you.
Precisely.
That seems counterintuitive. That's blowing up my brain as we talk about blowing up the brain.
So yesterday there was actually a little bit of a discussion about this in terms of chronic illness. So again, 20% of the people in the country use more than half of the resources, and 5% of people in the country use half of all our resources. Now, those are the people I should really be seeing. For you, I really shouldn't see you ever until your iPhone is showing me that there's a change in your blood pressure, or if you record your electrocardiogram, I'm seeing a change in the waveform that tells me that the heart is beginning to work a little bit too hard. Then I can call you or text you and say, now we need to talk. There's a little something here that's problematic. And that's really what was in the innovations that Tom was talking about yesterday, and actually Patty was beginning to talk about a little bit too, always on and continuous. I mean, your car more and more has the ability to tell you that you might need to see the mechanic. It's just we haven't gone that way yet. And so if you change rather than going in and paying a steep labor rate all the time, even if you were doing it preventively where nothing happens, you could ask, maybe that's a waste. But all that data is actually in the car. We just don't use it.
We're also taking your questions, pollev.com/txfm. Here's one going to your medical records question. Epic is an electronic medical records company, very well known to people in this room. And as we heard yesterday, there is a rollout right now for Epic going at Mayo. Do I have that right?
That's right.
How is it going is basically the question here. And is it going to serve or solve the administrative burden for physicians?
So the rollout is proceeding. It's been a long rollout for us. We're a huge organization. So the rollout occurred in Rochester in May, and the rollout in Florida and Arizona occurs in October and November. It is an electronic medical record. It has not, from a personal perspective, it hasn't made me any more efficient. In fact, it makes me somewhat less efficient, sometimes a lot less efficient. Ultimately, once we get it implemented, we will start looking at how we can make it work better for physicians and for patients. So there are many opportunities for us to work on that, and in our design and innovation group, we in fact have on the docket some ways that we can do that. That could reflect looking at information differently. One of the things that's striking to me is that we've created the electronic record, and it's really no different than having things on paper. So if you look at what my friends in cancer care do, even with the electronic record, they open up the computer and then they start reading. And they have a piece of paper and they start taking notes. And they're creating a timeline of what actually happened for a patient. When did symptoms appear? What were the diagnostic studies? What was the outcome? And then at the end of that, they turn around and they either rekey it in themselves or they dictate it. So they've taken the same information that was in the medical record, taken it out, analyzed it, and they've put it right back in again. That is a huge waste. So if you look at it that way, we've not made any advance in 25 years using electronic record in terms of improving the process of care.
How would you change what you just described to make it better?
So what we have to recognize there's a tremendous opportunity in changing the way that we visualize data. So the advantage of electronics is that I can stop saying I want to look at a record that's written, again, to match regulations that were promulgated in the 1990s. I could show a graphic display of some measure of a patient's performance or health over time, and overlaid on that, I would have all of the interventions, including the diagnostic studies that yielded, say, the diagnosis of cancer. All the data is in there. We just have to figure out a way to show it differently. So that's one of the things we're really going to work on in our design and innovation group over the next year.
Another question here. Can you talk about the sheer volume of potential information and how we might cope with this? How much of a barrier is this to the adoption of technologies by both physicians and patients, just that sheer volume?
So the sheer volume could be a problem if we did not have tools to deal with that. But more and more we have advances in computing that allow us to process those large amounts of data and then extract from that the few nuggets that would tell you that there's something here to worry about or not. And really, from my perspective, that's the most exciting thing that's coming in the next several years, is that I will finally be able to get relevant data, useful data, and it will be done in a way that's easy for me to utilize so that I don't have to sit down and pore over everything every morning that came in through the night.
Excuse me. I see on a lot of news websites, obviously from my world in journalism, the visualization of data, which is a huge thing in journalism too. How do you take all these raw numbers and visualize it in a way that people can understand? And you can see these beautiful charts of, you know, poverty increasing and income coming down, and you're beautiful, even things like election results, you know, how strong was this candidate in this county versus that county. And you can really sense, you know, you take a picture of the state of Minnesota, you're like, oh, they'll be strong here, et cetera, et cetera. And that really has taken off in an exponential way in recent years. And frankly, I think one of the reasons has to do with Jeff Bezos's purchase of the Washington Post. This is my personal opinion, but he has brought with him to this newspaper a lot of these behind the scenes technical, how do we do stuff to make it, you know, utilization and online stuff that I don't understand. Once it catches on, it really goes like a forest fire. Doesn't sound like we've caught on, you know, the visualization, the charts, the election results version for medicine isn't there yet.
It's because medicine is behind journalism.
Well, that's one industry.
No, actually, I think that's one of the things that's, again, is going to come fairly quickly. And then going back to Epic, I mean, could Epic have done that on its own? Probably, but the difficulty is when physicians submit a bill to Medicare, if Medicare comes back and audits the physician and they look at a graph, Medicare is going to say, well, that doesn't tell me that you actually did the process of asking a certain number of questions in the history, or that you examined a certain number of organ systems, and that you thought about enough things when you were trying to put all of that data together. I mean, that's the difficulty of the payment system going back with rules that are 20 years old.
Regarding the shift of payment for the outcomes of health, it shifts the focus of the provider to keeping patients healthy, as you talked about. Where does the role of patient accountability come in? Should provider reimbursement in this type of model be impacted by the lack of patient accountability in the health? If I'm paying you not to see you, but I'm also not pulling my weight, how does that affect that side of the world?
So ultimately, patients do have accountability and they will pay. So let me just give you one quick example. So if you come to me with atrial fibrillation and you are overweight and out of shape, I could prescribe a medicine to you that would reduce the likelihood of you having a recurrent episode of atrial fibrillation. And that medicine has about a 50 to 55% chance of keeping that atrial fibrillation from happening in a year. On the other hand, we also know from good scientific studies that if you could lose weight and achieve your ideal body weight and get fit so that you could walk 30 minutes a day at a pace of about 3.5 miles an hour, you're going to reduce the recurrence of atrial fibrillation by more than 55%, in fact, approaching 70%. So the accountability then is you can go buy a medicine, have to pay a copay, and possibly suffer the problems of more visits in the next year. Or you could go work on the things that make a difference, and by the way, you would feel better. Now, if you did that, your lifestyle would be better, you'd have fewer days of work lost, and all of those have a potential value. So I think it's a little bit of an oversimplification to say that patients must be accountable. I mean, patients are always accountable, and one thing that we have learned through our years of watching patients is that people have reasons for what they do. They're not always the reasons that we might think about, but that's okay. We have to find a way that we can connect with people and make it easier for them to make the choices that matter to them. Ultimately, they will have an economic cost as well because their insurance premiums may then vary based on their utilization.
Final thoughts here as we're about to transition to our group session, and the theme of this group session is part of what you were talking about. We're going to be talking about moving past incremental change to transformative changes. We had examples yesterday of look what we did in this one community, or look what we did in this one place. How do you make that transformational? So what are the kinds of things you're looking for, not necessarily from these speakers exactly, but just from that theme of moving from so many great examples at conferences like these of incremental things to transformative?
So again, what we've tried to do here is to give you examples of things that make a difference. But for us to really have that transformative change, we have to find ways that we can put them all together, synthesize them, or again, innovate the integration or the coordination. That will depend on all of us thinking about how we do things, working with people who are going to be our partners in producing health, and coming to those opportunities to innovate that middle. Sometimes in our group we talk about the messy middle of innovation. And that's really what we're talking about here, is we've got to find in the middle those solutions that will get everything together to make that true transformative change. So I hope that everybody here kind of thinks about that as you go home after the session today.
And you recently took over for your one-year term as the president of the Minnesota Medical Association, which largely means you are a spokesperson for the medical association. So it seems to me like these are going to be some of the themes you focus on in your term.
So really, when you think about the discussion and the debate yesterday, what you come down to, we are going to have to solve this together. It's not going to be government, it's not going to be retail, it's not going to be they, it's not going to be us, it's going to be everybody together to do that. And the theme that I've expressed to my fellow physicians is that if we want it to be, medicine can be the greatest factor for good. Now, for those of you who watched Ken Burns, you heard that. That's a Will Mayo statement. Charlie Mayo said, actually, medicine was organized to meet societal need. So the two Mayo brothers have actually expressed what the ideals of medicine should be. And one of the other Mayo aphorisms that we sometimes refer to here is that if we excel at anything, it is translating idealism into action. So what I hope for is that all of us, if we excel at anything going out of Transform today, it's going to translate idealism or translate what we've seen in this conference into action that is meaningful.
Dr. Douglas Wood, thanks so much for being here.
Thanks,
really
Tom.
Appreciate
Really appreciate your help.
Thanks so much.